The immunological mess. Why we call it mess? Because it's when we talk about immunological, as I explained a bit earlier, it's not one factor. Several factors play a role. Myeloid-derived inflammation, cellular response, and this cellular response consists of expansion of specific cells like myeloid-derived suppressor cells, Tregs, T-cell exhaustion, NK cell dysfunction, myeloid cells dysfunction like dendritic cells. They cannot present antigen properly to the immune system, to T cells. Expansion of a specific monocyte, for instance, that they are also inhibitory. So several factors are there, and it's a mess because you have inflammation, you have all of these changes in cellular components of immune system. And when you talk about it, you think, wow, this is a mess. So many things happening at the same time. What is going on? One is, well, not all happens once at the same time. Most likely it's a stepwise progression. And when we see patient, of course, it's a mess because all those steps are taken. And when we see the patient, it's a mess. Yes. But the second question is, when perhaps it's not a good idea to consider MDS like any other aspects of MDS. When we talk about mutation, when we talk about microenvironment, not all MDS patients are the same. The immune side is more or less the same as those other two aspects. Not all patients, they have the same feature of immune system. Some patients may have more of the inflammatory or myeloid-derived inflammation predominantly, whereas the other patients may have more of the autoimmune subtype of immune response. If I want to give you an example, those MDS patients with sweet syndrome are most likely the patients with the extreme myeloid-derived inflammation. And those patients with, most likely those patients with, for instance, hypoplastic MDS, how we define it, of course, it's a different story. But if we define hypoplastic MDS, it's likely that they have a picture that it resembles somehow immune type aplastic anemia. Not exactly the same, but closer to that. And more of the autoimmune type response or auto T cell response that you can see here, similar to aplastic anemia. And that's a range. So you, in one end, you have autoimmune type or immune type MDS, the other type may be inflammatory. And you may have types that really immune system is not a dominant feature of this disease. A patient with multiple mutations with a very high percentage of loss, perhaps that patient passed the stage of immune system being a dominant feature. And this is important because these days there are several clinical trials that we are using immune modifying medications to treat MDS patients. But how we choose that? Are we choosing them wisely? If I give you a historic example, is immune checkpoint blockade, that in MDS, when in other cancer was really a good response in so many of them, in MDS was relatively disappointing because the percentage of response wasn't very high. But some patients actually respond. How do we choose those patients? We use revised IPSS to decide about the risk of disease progression in MDS, which is extremely helpful. It's very, very useful tool to predict the outcome of MDS. But is that really a good predictor for response to any type of immune treatment, immune-related treatment, or immune modulatory drugs? I don't think so, because not any of aspects of IPSS is really related directly to immune response in MDS. So it seems like in longer term, we need to decide what elements of immune system to be considered and to be used for selection of patients and stratifying MDS patients, two types that consider inflammatory, two types that consider, for instance, autoimmune type, or not necessarily autoimmune, but more of the T-cell response type, those that with immune suppressed type. And then you can, if you can decide and stratify patients to these, for instance, these three subgroups, we can decide, okay, for inflammatory, we can give different drugs, we can inhibit the TLR and inflammasome pathway. In those that they really have kind of autoreactive T cells, resemble aplastic anemia to some extent, we may go for immunosuppression using ATG, for instance, or those patients that they have a very immune suppressed feature, we need to revive the immune response. Can we do vaccination? Can we do combination of vaccine and checkpoint blockade, or other combination that can be used? I think that's the key to overcome this mess and select patients based on the phenotype they have. And this needs collaboration between different centers, look at a larger cohort of patients, and redefine a kind of immune classification for MDS. Therefore, we can better treat them and better use the immunomodulatory medications that are available now.